Hi everyone, our subject today is pruritus or itching in pediatrics. Basics. Pruritus or itch is one of the most frequent dermatological complaints. It is an unpleasant sensation characterized by the reflexive behavior to scratch and is a symptom associated with the numerous inflammatory and infectious skin disease. However, generalized and persistent pruritus without or with minimal skin changes may be a presenting feature of a variety of systemic disease. In contrast to adults, generalized pruritus due to systemic disease like liver, diabetes, renal is rare in children, with the exception of dry skin, which is very often inherited as autosomal dominant. The most common two causes of pruritus in children are dry skin and atopic dermatitis. The perianal area, nappy rash, atopic dermatitis, threadworms, vulvovaginitis, and hair area, pediculosis, scabies are the common localized site of itching. History: acute versus chronic, more than 6 weeks of pruritus. Location: generalized, scattered spot or localized. Severity of symptom: presence or absence of preceding or concurrent rash, family member or close contact with a similar complaint, environmental exposure, pets, other animal, poison, oak or IV, skincare, products, soap, shampoo, length and frequency of bathing and showering. Medication history, topical or systemic or recreational drug. History of hematological disease, hepatobiliary, renal, metabolic, neurologic, neoplastic and psychiatric disease. Complete review of systems, particularly important for those without obvious skin finding. Physical examination. Define and differentiate primary morphology from secondary changes. Determine the location of the rash and area of sparing. Evaluate for evidence of secondary cutaneous infection. Approach to the patient. Most children with the pruritus have a primary dermatological disease. Common conditions include atopic dermatitis, allergic reaction to insect bites, so-called papular urticaria, fungal infection, scabies, hives, and dermatographism. To develop a differential diagnosis, it is helpful to subdivide patients into one of four groups as below. Generalized pruritus with the defined skin disease, generalized pruritus without defined skin disease, minimal or non-specific skin lesion, localized pruritus with the defined skin disease, localized pruritus without defined skin disease, minimal or non-specific skin lesion. Question 1. Are the finding characteristic of atopic dermatitis the most common skin disease in children? Does the patient have a history of severe cradle cap or a chronic intermittent rash involving the face, antecubital or popliteal fossa, ankles, or wrist? Atopic dermatitis is very common and typically has a distinctive site of predilection. Question 2. Are there specific or non-specific scratching, rubbing, induced skin lesion present? If there are multiple morphologies, consider scabies. If minimal or mostly secondary skin changes are present but pruritus is severe, consider either scabies or a systemic cause. Question 3. Does the patient have clustered pink excoriated papule on the ankles, mid-torso, or leg? This finding may represent bug bite reaction, which are a common cause of pruritus in children. These reactions disproportionately affect young children and may not be evident in their parents, guardians, or even siblings. Question 4. Does the patient have acute onset of rash with a tiny vesicle or linear streaks of erythema on the face, arm, or leg. Poison oak ivy is common and presents as an acute eczematous or vesiculobullous reaction. Question 5. Does the patient have a well-defined erythematous and scaling rash involving the scalp, extensor, elbow, knee, umbilicus, or gluteal cleft? These findings suggest psoriasis, although less common in children than atopic dermatitis and usually less itchy. It has a distinct site of involvement with the characteristic morphology. Family history of psoriasis is common in patients who developed in childhood. Question 6. Does the patient have a chronic pruritus scaly rash around the umbilicus? Chronic allergic contact dermatitis from metal, especially to nickel, may present as an isolated itchy rash around the umbilicus due to belt, knuckle, or pant bottom. For patients who wear earrings, earlobe may be affected, providing a diagnostic clue. Many patients with the nickel dermatitis have fine papules scattered on the arms and legs, so-called id reaction, or may have pre-existing atopic dermatitis. Question 7. Does the patient have any itchy rash involving the cheeks and nose with the rash on the dorsal forearms sparing the volar arms? This pattern may present photosensitivity and suggest possible polymorphous light eruption or actinic prurigo. For patients with a definite dermatological cause for pruritus, treat the underlying cause. Consider non-dermatological cause for patients with the severe generalized pruritus and non-specific skin lesion. Exclude scabies infestation, dermatographism, and atopic dermatitis. Localized pruritus with minimal or non-specific skin lesion may suggest neuropathic itch, which is rare in children. This is simple differentiation. Atopic dermatitis, mainly on the flexors, worse at night, cause obvious on skin, positive family history. Food allergy could be, this is generalized and possible positive family history. Dry skin, also generalized with possible worse at night, cause obvious on the skin with positive family history. Parasites, worse at night with possible cause obvious on skin and positive family history. Urticaria, generalized with the cause obvious on skin. Recommended investigation. Investigation of pruritus is essential for children who are both without physical finding and not responding to a short course of antipruritic therapy. Investigation include complete blood count to confirm anemia or eosinophilia in allergic condition, fasting blood sugar, urine analysis, and hemoglobin HA1C to identify diabetes mellitus. Urea and electrolyte will diagnose chronic renal failure. Liver function test in patient with jaundice. Thyroid function test to confirm hypothyroidism or hyperthyroidism. Scrubbing from burrow to diagnose scabies. Top tips. The vast majority of conditions causing pruritus are obvious. The diagnosis is entirely clinical and based on the nature, distribution, and duration of the lesion. Seborrheic dermatitis is often difficult to differentiate from atopic dermatitis. Pruritus is always present in atopic dermatitis in contrast to seborrheic dermatitis. Atopic dermatitis is the most common skin disease in pediatrics. It is a chronic, relapsing, highly pruritic condition affecting 10 to 20% of children, commonly associated with elevated IgE level and staphylococcal aureus colonization. Pruritus is always present in atopic dermatitis. If absent, the diagnosis is incorrect. There is no cure or shortcut to the long-term management aimed at relieving the symptom, including the itching. In infant, warm warping and warm ambient temperature are common cause of restlessness, sweating, and scalp pruritus. Remember that poor hygiene is often the underlying cause of scalp itching, such as pediculosis. Examination of the child may confirm other area of his or her body with the poor hygiene. Bully, pustule, and dermatitis of the skin and scalp dominate in infants with scabies. In older children, small papules and vesicles localized in the interdigital space and wrist flexor are seen. Wood's lamp is a useful tool to have. Blue-green fluorescence is detectable in the hair shaft if infected by fungal infection. Tinea versicolor has golden fluorescence in a dark room is needed. As lice and ova nets are often hard to see in fair hair, the best way to identify lice is to comb the hair properly with the louse comb, preferably from the hair behind the ears and back of the neck. A common cause of scalp pruritus is contact dermatitis due to the use of soap, shampoo, and other hair products, particularly those that contain alcohol. Scalp nevi often cause anxiety for professionals and parents. Dermoscope is a non-invasive tool in the evaluation of these nevi, including melanoma. In children with the impaired immunity, like HIV, or receiving immunosuppressive drugs like steroid, widespread and serious scabies rash with the thick scaling may occur. Norwegian scabies. The mite are able to multiply to thousands. The nail become thickened and dystrophic. Red flag. Infant with restlessness, discomfort, and excessive crying, particularly at night, may well have pruritic systemic disease such as non-ecteric cholestasis. An atopic dermatitis which does not respond to conventional treatment is very often due to staphylococcal aureus or less commonly fungal infection. Improvement should occur with the antibiotic or antifungal treatment even in the absence of clear sign of infection. Any skin dermatosis with the intense pruritus, particularly when the child is in bed, should alert the physician of the presence of scabies. Eczema herpeticum resulting from dissemination of herpes simplex virus in atopic dermatitis can cause keratoconjunctivitis and multi-organ involvement leading to death. Prompt recognition and antiviral treatment are essential. Risk factor for this infection includes severe atopic dermatitis and marked IgE elevation. Children presenting with a pruritus of the hair with the pyoderma and cervical and occipital lymphadenopathy should be regarded as having pediculosis capitis until proved otherwise. Treatment is urgent. Generalized pruritus could be the only symptom of obstructive jaundice before the jaundice appear, like primary biliary cirrhosis or drugs, and that of chronic renal failure. Any perianal or perineal pruritus at night should alert the clinician to the presence of worm. Inspection of the area by parents while the child is asleep often confirm the diagnosis. Although pruritic Patchy alopecia is often caused by alopecia areata or tinea capitis. Discoid lupus erythematosus and secondary syphilis should be considered in differential diagnosis. Fever, regional lymphadenopathy, and widespread pustules caused by bacterial infection often complicate pediculosis, tinea capitis, and scalp dermatitis. It is essential to search for the cause of this inflammatory response. Melanoma of the scalp is associated with the worst prognosis compared to the melanoma located elsewhere on the body, mainly because of the invisibility of these lesions in the scalp. Differential diagnosis of itching: dermatological disease, inflammatory skin disease, dermatitis, atopic including nummular morphology, allergic contact, irritant contact, and other, urticaria, dermatographism, psoriasis, lichen planus, mastocytosis, dermatitis herpetiformis, bullous pemphigoids, epidermolysis bullosa prurigosa, polymorphous light eruption. Cutaneous infection and arthropod reaction, scabies, tinea, dermatophyte infection, pediculosis, fly bite, mite reaction, bedbug bite, papular urticaria, C. Bather eruption, and other arthropod reaction. Neoplastic like cutaneous lymphoma, systemic disease, endocrine like thyroid and parathyroid, diabetes mellitus, infection, HIV, hepatitis B and C, systemic parasitic infection. Hematological cause, polycythemia vera, aquagenic pruritus, iron deficiency anemia, lymphoma, leukemia, hypereosinophilic syndrome, myelodysplastic syndrome. Biliary disease leading to cholestasis, renal disease, uremic pruritus and chronic kidney disease, malignancy, solid tumor, carcinoid syndrome, pregnancy. Remember that some drugs like iron, zinc, and opioids can directly cause itching. Other drugs like chlorpromazine may indirectly cause itching by causing obstructive jaundice. Neurological disease like CNS malignancy or infection, multiple sclerosis, peripheral nerve injury from compression or irritation, radiculopathy, polyneuropathy. Psychiatric disease, psychogenic excoriation, delusion of parasites, and somatoform disorder. Thank you for your listening.